My name is Danielle Rahajasan. I am, and on behalf of the National Center for Medical Legal Partnerships and our panelists, I wanted to thank you for taking the time out of your very busy schedules today to attend this session. We are very excited to welcome you to the third of a four-part session learning collaborative that will focus on using legal services as part of a community strategy to improve maternal and child health. In just a moment, I will turn this presentation over to our panelists, but before that, I have a few small housekeeping things I would like to run through with everyone. You did join in on mute, however, you will be able to unmute yourselves to pose any questions during the breakout sessions and or Q&A session throughout the collaborative. We are using a Zoom for our event today, so if you do have questions, please type and send those in the chat so that the panelists can see them and can connect with you. We also want to acknowledge that this project is supported in full by the Health Resources and Services Administration, and that the contents are those of the authors and don't necessarily represent the official views of HRSA, HHS, or the US government. So for more seamless transition to our breakout today, we ask that everyone change their display name to reflect your room number. So to rename yourself, click on the participant icon in the Zoom toolbar. Then next to your name, you can click more and choose the rename option. Then you can enter a new name, which is going to be your breakout number followed by your name. So for example, if your name is Jane Doe, you would write 1-Jane Doe, and that should do it. And we will also put these instructions for you in the chat for convenience. You should have also received an email from Catherine Stinton with a copy of a blank SMART Goal Action Worksheet, which we will also share with you in the chat for your convenience. And just a reminder that today's audio recording and slides will be emailed to everybody by next week. So we are all familiar with our faculty at this point, as we have heard from all of them, but today's session specifically will be led by the Center for Children's Advocacy at the Yale School of Medicine team, represented today by Dr. Ada Fenick and Alice Rosenthal. So I know we're all very excited to hear from our panelists, so without further ado, I will pass it on to the Yale team who will introduce today's agenda.
Great, thank you guys all for coming back and being here with us. We'd like to cover a bunch of different things today. We've got only an hour. We all realize that we really should have an hour and a half for every session, but this is an hour this time. We've got, first, we're going to kind of explore what legal issues are really impacting children's health, what really makes child MLPs different. We will talk about a patient story to give you some MLP in action, and then really cover the nuts and bolts of our MLP, just to kind of give a feel of, what are the different steps in it. And then we're going to try and tackle your wishes and pain points, also known as implementation strategies for your site, and we're going to do that in our breakouts with your teams. So the first thing is really a brainstorm, and for this we welcome you to either put it in the chat or really unmute and talk about what kind of things make children's MLPs different. What are your thoughts?
My first thought is consent, dealing with minors.
Fabulous. I realize I can't see everybody who's talking, so I'm going to try and make pictures bigger. Keep it coming. Oh, there's some things in the chat. So I love that people do that. So unmute if you want to, but I'm going to read some things that were said. So one is, who is the client and consent and so on. Somebody said, Danielle says, pediatricians are often natural advocates. And the next real thing is, it says the client is not the patient in many cases. And I think that's all absolutely true about the children's, we're talking here a lot about the children. Sorry, I've lost my pointer. Here we go, because I've opened the chat and everything else is open. What about the kinds of law?
someone actually had just answered that. We
Oh, I
often
didn't
get
see it. I'm
different
sorry. I
types
closed the
of-
chat because it was making me
Yeah,
crazy.
I'll do it. I'll do it. We often get different types of cases in our child-focused MLP compared to adult ones, education cases, for example.
Great.
We also got some, sometimes the guardian is not the legal guardian in children's MLPs.
Mhm.
And it can get complicated with state laws around releasing records, around mental health and other things, and other legal decision making. So that same with the consent.
Mhm. So I think when we were brainstorming, we came up with a couple more really, really different things other than education law. And I'm not a lawyer, I'm the doc, but we had talked about the fact that teenagers have different legal rights depending on the state you're in. And so the parent may not be able to participate in some of those pieces, or there might be ways that teenagers are able to access their rights differentially. Let's put it that way. And then also child SSI is different than adult SSI. So that was kind of a critical thing. So I think those were the three big areas of law that we had talked about. Anything I'm missing, Alice?
Yeah, Amari said also for immigration issues, there's special immigrant juvenile status
Excellent.
for kids that you don't get for adults, which is something that our office does a lot of. And then Abby also said trauma-informed advocacy can look different with children.
Wonderful. Excellent. You guys are very activated. I love it.
So these are just a quick breakdown of the type of legal issues that we see on our children's MLP here in Connecticut. This is obviously after we've trained them and they know what kinds of issues I do. I know someone had put in one of the responses, I want to think about how we can hone what kinds of legal issues the docs know that we do so that we don't get this whole big umbrella. And so we've worked hard at doing that. So these numbers don't reflect what issues come up for kids in general, but mostly what the types of issues that we work on our MLP, partially because of the type of legal organization I work for, and also just the type of legal issues that we think are so impactful for children. So the main ones really being housing and particularly housing conditions. Education is huge, and education really doesn't come up in any other type of MLP, but a children's MLP. But kids spend so much of their life in school, but also when they're little and when they're older as well. And so that is a huge piece of children's MLPs. We do a lot of utilities work along with the housing, public benefits, SSI benefits, like Anna said, are different for kids. And then I do a portion of guardianship. And we also do a lot of disability rights stuff. And then I just want to say that's not on here, but like Anna said, teen legal rights in Connecticut, we have some of the broadest legal rights for teens to consent to their own healthcare in a number of areas. And so we do a lot of education and training around that. And then I work really closely with our gender program. So I work with a gender non-conforming youth around healthcare denials and other things in that realm. So this is a broad amount of issues, but we just wanted to give you a snapshot of what they look like.
And just so that people realize, I mean, these are the things that you deal with, but there are, of course, because there are other legal issues that surround children, you have a wide network of people that you refer out to if you need to. And when we get a guardianship case or something that, I mean, you do a little of it, but often you'll refer that out. Is that right?
Yeah, that's a great way of framing it. I know that a few people had asked about children's MLPs related to child welfare, and my office does a lot of representation of children in the child welfare system, but our medical legal partnership does not. Just because of the nature of the work that we do, I couldn't take on representation through the courts on that area. But I think what a lot of people have said around custody, but also around like who's the decision maker, comes up all the time. And I work really closely with legal and risk services here at the hospital because they often provide that kind of guidance to the providers as well. But because I'm boots on the ground in the clinics, people often will ask me as well. So who can make the decision and who do we talk to? And so we all are working as a team collaboratively to make sure people understand who is that decision maker for that particular child's. Someone had asked, can it be difficult to get an accurate assessment of a family's social determinants of health if the parents are at all concerned about getting social services involved? Yes, that is a great question. I have found often that the doctor will say, you know, we have a wonderful social worker in the clinic. Would you like to talk to them? And a lot of times parents say no, because they're afraid talking to the social worker then means DCF gets called. And when the doctor says, we have a wonderful lawyer in the clinic, would you like to talk to them? 99% of the time, they're like, oh yeah, I want to talk to that person. So yeah, there is a concern around that. And sometimes, and again, I work really closely with the social workers and the nurses and the providers so that wherever they talk about that, we are clear about that. But then for me, I'm very clear that my work is confidential with the family. All right, let's talk about it in action so we can try to think about what we're talking about. So Joey was a 15-year-old patient who had a whole host of medical conditions, saw tons of specialists, cycled in and out of the hospital, including psychiatric disorders, and constantly was coming into the emergency room and inpatient to address those needs. And so Ada and I did a quick look at this one case to just track how many admissions he had before MLP intervention and then after. And as you can see, he had a lot of admissions over the course of about a year and a half due to a variety of all these different medical conditions. And go ahead, Ada. And because of this, he was frequently absent from school, and the school didn't know how to address all of his complex medical needs. This was before COVID, and imagine after COVID, it would be worse. So they were giving him home instruction and telling him to stay home. Because of that, he felt really bad about himself and started to have school failure. So mom kept fighting with the school district, saying he can't just sit at home doing nothing. The school kept pushing back and saying, we don't have a program for him. He kept getting more and more anxious, and that was impacting all of his other medical conditions. So let's keep that frame in mind as we think about MLP. So we talked about this at the first session. We know that some of you have MLPs already, but I'm just going to reflect back just so you get that sense of how it really worked in action for our children's MLP. Our office does, not only are we in a children's hospital, but we do what we like to call the three-legged stool. We do education and training, consultation and representation, and systemic advocacy. And education and training being a huge piece of what we do. I know someone had said they wanted some resources on how to train doctors and providers around identifying social determinants of health. And so we'd be happy to share any of that stuff with all of you, but it's a huge part of how we get providers to screen for social determinants of health. And we do at least one a week to fellows, to medical students, to anybody who will listen. And then a lot of what I do, sorry, was there a question?
No, that was me laughing. Anyone who will listen, I like that. Sorry.
We do a lot of consultation to providers directly. So about 50% of the work I do is just giving an answer to somebody, because we don't want to re-traumatize someone or have to make them stay longer or retell their story. And so I find it to be incredibly impactful, mostly because I can help more people, but also can sort of give that quick answer that they don't need sort of a full intake for. And then of course I represent families and work with them directly. It also really helps providers when I give them the information to then remember, oh, next time I can tell the family without having to ask Alice to go here. And so I think it's another way of doing education and training. And then the last thing is systemic advocacy. No, that's good. Is really taking that patient story and looking at it at a bigger lens, which hopefully we'll talk about at the fourth session, but also happy to share some of the stuff we've done. And then just to expand upon all of those, Ada and I do a lot of interdisciplinary education. So her and I co-teach, remembering that medical legal partnership is so beautiful because it's working together. And so we find that doing the trainings together can be really a great way of showing both sides of the M and the L. So like I said, we do them to give lectures to medical students, residents. We're in the curriculum at the medical school. And so we sort of have a core curriculum down. We also, my office also has a ton of Know Your Rights guides in a variety of areas. We recently put together a trans youth Know Your Rights guide. We also, during COVID, Ada and I worked hard on putting together a resource guide that was in the EMR that anyone across the hospital system could print out to people who were struggling to get by during COVID. We also have an advocacy track for residents to participate where they can shadow the MLP or they can do advocacy in the community. And so we supervise that. We put on a conference and other things. We get about 300 to 400 patient referrals a year. And again, on all the issues that we talked about. And then some legislative advocacy we do a lot of. We changed here in Connecticut, we got rid of the religious exemption for children's immunizations. We also were part of the right to counsel in Connecticut, which although you don't think of that as children's law, you think of it as sort of law that impacts everybody, but it has such a huge impact on our children's patients. And then this year we're working on a bill around reducing the lead levels in Connecticut. So kids, we stop using children as lead detectors. How are we doing on time? We're okay. So thinking about how we are in action, we decided that I should sit right in the clinic. Even though I'm for the whole health children's hospital, I sit in the outpatient clinic, and every patient that came through the doors of the clinic were able to pass by my office, which as a lawyer, those of you on the call would know that that's not a great way to practice law because you can't actually get your job done, but it was incredible to be visible. So I encourage those of you who haven't done one yet or who are struggling to get referrals to be as visible as possible. And we did screening across a whole different variety of ways. We had We Care screeners, we had trainings that we do for people. We have me just sitting in the clinic and screening. And so once they screen, they would refer to us and we would decide whether or not it was something that I should just give back to the provider or if I should talk directly to the family. And because again, I'm here in the hospital 5 days a week, I can run up to the floors. Like there's a patient upstairs waiting to see me after this presentation because they're inpatient and just need some quick information about education. It gives me the flexibility to really be available because we all know that hospitals work really fast, except for the patients that we can't move through the hospital and stay here for a long time, that they really want to meet them where they're at. And so it's a great way to really be embedded in the hospital. And then we really do try to give feedback to the clinicians team, but only after we get permission from the family. I don't chart or write into the EMR. And then of course, in all of this, there are areas that we could always improve upon, being the feedback one. Ada and I realized after hearing Roxy last week, we really should be doing better feedback.
I think that's why we made it a white arrow instead of a gray arrow.
Totally. See, you can just keep learning after 9 years. And rethinking how you do stuff. That's why we were hoping to share this stuff with you guys to think about how we do it, but this isn't the way everyone has to do it. And then we wanted to put in these extra little pretty things to think about, like, again, the screeners, like I said, once providers start learning how to do it, they do some of the referrals themselves. We have 2 of the residents now attendings here put together a resource list online called Flourishing Families. So providers can go right up there and find resources. Every state in the United States has the 211 or info line, like 311, 401, depending on where you're from. And we did a lot of form letters so that providers can fill out form letters around school issues or other things. And then of course, thinking of the interventions, we always take our advocacy to the next level if we can, keeping in mind it's just me. And then just keeping in mind about the trainings. One thing I just want to highlight is a couple of years ago, my office moved out of the clinic. And although the referrals didn't drop drastically, I definitely think that visibility was a key in shifting sort of some of the work that I do as a lawyer here in the clinic or in the hospital. Does anybody have any questions or thoughts or things they want to? throw in so far? It's a lot of talking. We're going to go talk in our room soon, but.
So let's wrap them up.
All right, we'll wrap it up then. So mom got really frustrated and told the providers and said, I can't do this anymore. And the provider said, oh, we have a lawyer. Maybe she can help you. And so I met with the family. I worked with the child psychiatrist and all their medical providers. And we decided that really what was happening was the school could care for this kid. They just weren't giving him the extra special ed support he needed. And so we fought with the district and got them to agree to a special education therapeutic outplacement where he went during the day. And it was really wonderful. And after he started there, go ahead, Ada. You can see his admissions dropped drastically. When we showed these numbers to the CEO of the children's hospital, she was like, huh, that would probably be your whole salary for a couple years. And I was like, yes, it would. So just even this one case, reducing those hospitalizations because they're Medicaid, right? And the return on Medicaid dollars is a lot lower than private insurance, saved the hospital the amount of money that it would cost for my program for at least 1 to 2 years. And so we don't do a lot of return on investment because it's really complicated here. We don't have a full-time evaluator, but it's something that we hope we can talk about in the future about how you can really show the cost value and the savings to the hospital of having a medical legal partnership. But most importantly, you had a 15-year-old who felt really good about himself and started going to school all the time. And because he felt so good about himself, he stopped having some of the stomach problems, some of the neurologic problems, some of the psychiatric problems, because it was all connected. And he's doing so much better. And I think just recently graduated from high school. So yay story.
Totally wonderful stuff.
And I love working with kids because, right, we're always thinking about how can we improve kids' lives. Like kids are cute. And that's why the hospital here wanted to do a kid MLP first. Because you can sell
It's
it.
funny, we didn't say that as one of the differences between a child MLP and an adult MLP. So uniformly, pretty much, kids are cute, right?
Yeah.
All right. So now we're going to flip to tackling your wishes or pain points that hopefully you wrote down as part of your homework. Just to remind you what you did. Your homework was to identify an intervention. So your question to really think about was, what do you wish you were doing now that you are not yet doing now? And think about an MLP action that you're really hoping to do in the next 2 months. And then we wanted you to write a goal statement, and we wanted you to do it in this kind of very measurable and doable way called a SMART goal: specific, measurable, achievable, relevant, and time bound. And so these were 3 examples of SMART goals that we sent you guys, all at different levels of the kind of MLP functioning, right? So hopefully you guys have written that down, so please pull it out because you're going to need it. And we sent you a paper through this piece to go and do this, a paper to read about what is a SMART goal, specifically as it relates to legal services. So now you've identified that already. That was your homework. So now we're going to take some action on it. And we're going to go into the breakout rooms. But I first want to give you a little bit of a talk about kind of how to decide what changes to make to get to your SMART goal. So the thing to think about here is a key driver. So a key driver is kind of the main point in the system, whatever your system is, that's going to create change. And then your next question is, how do you affect those main points? And so obviously that's very context dependent. And so what you would go from is this problem, the central problem, and you think about the different primary drivers, and there might be multiple ones. I'm going to give you some examples, so don't get frightened yet. I'm just going to kind of draw it out and then give the examples. And each one of those may have a secondary driver that pushes those, and it actually could go a little further, right? And then after you finish kind of figuring out what the drivers are, why is this happening in this way? Then you might start to think about some changes that you might want to try out to see if they work. And some changes are going to be easier to do, and some are harder to do, and some may have more of an effect or less an effect. And what you really want to focus on are the ones that are a little easier to do and will have a lot of effect, right? That sounds easy to Easy to say, possibly harder to do, but trust me, that's kind of where you want to be going. So for example, here's a SMART goal example. So, somebody, say a president of ours, might have said, well, we need to get COVID vaccination over 80% by July 2021. And he told somebody, try to get this done. Okay. And they thought to themselves and they said, okay, that's our SMART goal. What are the things that feed into that? What are the things that can cause that to either happen or not so much happen? And so what are some of the primary drivers? Well, there are people who fear vaccines and may not be getting the vaccine because of that. There might be some people who don't trust the government, and the government made these vaccines, either the current government, the prior government, whatever it was. And another one might be cost of vaccines. Now, I don't have access to any governmental files or anything like that. This was just me thinking, okay? So this is not coming out of the government. But these might be some things you think of as primary drivers of trying to get the vaccination rate up to 80%, okay? Then you might go for each of those and say, well, what is a secondary driver to that? So, maybe your clinicians are not that reassuring yet, right? Maybe there are people who have needle phobia who really can't abide by the thought of having a needle. And maybe kind of the media divisiveness is really driving both the fear of vaccines and a distrust in government. So you might have a secondary driver that affects multiple things. Does that make sense? I'm hoping for some nods. Okay, I see people, so I'm hoping for nods. So then you might have some ideas for things to change. So for example, you might say, well, we can train clinicians both individually to talk to families in a different way, or in how to deal with media, to get on TV and kind of be reassuring on the media. So, and work that way. And so that might help both. That might have two of your problems in that case. Developing intranasal vaccines that can be given in the nose instead of through a needle, well, that'll do a lot to combat needle phobia, right? So that might be something that you might think of. And so you can see that you could go through a lot of these different areas and kind of think about what are the secondary drivers for each of these, what are the changes that you might want to make. Now, here's one example that was published. And so this has to do with HIV documentation of HIV status. And this was in Massachusetts, and it was published. This is a published key driver diagram, okay? So similarly, again, you've got this overall project goal over here, the aim. And so they said, minimize the chance of missing an opportunity to prevent HIV transmission. And they said, we want to document. We want to go from 50% to 100% documented maternal HIV, positive or not. And so they came up with two primary drivers, the lack of universal testing and failure of communication. And then they came up with secondary drivers for those. And they came up with change concepts for each of those. So kind of it all feeds in together to move your primary aim in the direction you want it to go. So this is kind of just flipped, but it's a similar kind of thing. This is a way to kind of start thinking about what are the different kind of primary drivers. So this fishbone diagram, here are the problems on the right, or the goals on the right. And you can see the primary drivers feeding into these different kind of categories. And so this, I think Professor Ishikawa came up with the idea that these can be bucketed a little bit into the people that you work with, the processes that are in place, et cetera, and that each of the drivers could be a part of one of those. And then secondary drivers feed into the primary driver. So every time you see this little arrow, it's a secondary driver. So that's kind of just another conceptual way to think about how to get to your primary drivers of your problem. It just flips it around. And so here, this exact thing is just the same thing. It's just a flipped Ishikawa diagram, essentially, but I didn't draw it out exactly the way he did. So here's an example, right? You want a specific patient behavior change, and that would be patient barriers, there might be priority barriers, there might be system barriers, and you can kind of go into each one of those different little things and kind of get the idea that you can kind of see what funnels into your ultimate change. Okay, so here's one more example. I don't want you to be scared, but these can get really complex, right? So that's why I wrote don't be scared on here, because for your system, systems are complex. And so for your system, you might find that you can really dig down into the nitty gritty and really go into the depths to really figure out what little things you can change. Where are the little levers that you can push to change? So here's an example of a really complex one. So the EMS run report, that's the emergency management system, the ambulances, sometimes the reports are not so accurate. And so they went through and tried to figure out, like, what are the different levers that we can push, usable information, or that the method of doing these reports is tedious and manual. So, so they could figure out, like, what can we change to make it easier? Okay. So you want to think, like, how do I figure out my key drivers? And so there's two big methods that I like to think about. So one of them is to really ask your newspaper questions of, who, what, and when, where, and how. And the who is really the people that are involved. The what is kind of what you're trying to do, or what are the different pieces of what you're trying to do. And then the when, where, and how are really very much processed questions. So that's kind of one bucket of thing, one mechanism for trying to figure out your key drivers. And then the other one is kind of asking these 5 whys. So this has kind of been published multiple times. The idea is you might say, well, my screening's not documented and I want to get my screening not documented. So you can ask a question, well, why is my screening not documented? And you'll come up with the top answer. People don't remember to do it. Or you might come up with another one. You might come up with 5, right? Because those might all be key drivers. But for example, you say, well, people don't remember. Well, why don't people remember? Well, there's no prompts in the HR. Well, why are there no prompts in the HR? Well, because it's hard to change templates. But why is it hard to change the templates? Because of EHR governance. So, EHR governance is there because of need for standardization. So if you manage to change the standardization of all the templates, you can probably get to the point where you get screening documented. So you can delve down really far. You don't have to go as far as 5 whys every single time, but the idea is if you go to the 5 whys, you might get to the point where you're really getting into the nitty-gritty depths of what you're trying to document, of what you're trying to change.
Margaret also said that it's you could use journey mapping if you want to utilize more of a design thinking methodology.
That's beautiful. Thank you. Love it. So we now have until 1:55, about 20 minutes, to make a key driver diagram for one of our problems in the group. So somebody in the group, in each of the groups, is going to have a problem. So the idea is for about 2 minutes, we're going to discuss some of the wishes within the group, and everybody come to some kind of consensus about whose you want to talk about. And then we'll work on one person's key driver diagram just for a little while. At the end, we'll take a screenshot and make sure we send it to them. And so what we'll use is kind of a driver diagram template. Here you've got your aim on the left, your primary drivers, secondary drivers here. Now there's no arrows here because I don't know if there's going to be 3 for this first thing and the 2 for the second thing. We'll fill in the arrows. It's not a big deal. And then the change idea off to the side, like how can you change this secondary driver? Now you may find that there's 3 things that are still affecting your secondary driver. Like if you did, this is only 2 whys. Why have you not gotten your SMART goal? Because of your primary driver. Why have you not gotten your primary driver? Because your second. You might find 3 things before that. And that's okay, you can fill them in. You can add little pieces in.
All right, first let me thank, this is Bethany from the National Center for Medical Legal Partnership. Let me thank all the participants for engaging today with some very rich conversations. As we'll share with faculty, all faculty, the notes that were taken and captured. To our faculty members from Connecticut, the CCA, Yale, New Haven Health team, thank you very much, Alice and Ada, for presenting today and for guiding today's conversation. So the National Center for Medical Legal Partnership team will send out another follow-up email. We'll update the welcome packet with any additional resources that came out of this conversation today. And we're just asking everyone who participated to take a moment to review those goals, the goal statements that were shared today during the breakouts and the ones that you did as the homework session. Really review the goal statements that you made and then take a look at the objectives, right? Are you finally able to form some objectives? On the screen, you'll see that we're just providing you with a little bit of guided language to help you plan out, like, what is your goal, right? What's your SMART goal? And then in the next time period, right? The when, the who, what, when, where, and how, right? In what time period will you do or get done certain actions that get to that, achieving that goal? Some things to consider: who are the possible partners? What are some of the processes that you'll need to put in place, such as screenings, referrals, and feedback to medical providers, and how will you track data? Those are some of the things we want you to think about in the interim before joining us back for session 4, where we close things out on April 14th, same time, same place. If folks are willing and able, we may extend that one a few more minutes because we don't want to cut these really, really robust conversations short. So with that, look out for the follow-up email. And thank you all for joining us today. That's a wrap. We'll see you back here on April 14th. Take care, everyone. Be safe.